Androgens. So the androgen action involves pre-receptor, receptor, and post-receptor mechanisms. They're centered on binding testosterone to the androgen receptor. And then testosterone undergoes pre-receptor activation by conversion to potent bioactive metabolites, which are DHT and estradiol. Now, let's talk it in more layman's terms. Androgens are crucial for male sexual and reproductive function. They are responsible for the development of secondary sexual characteristics in men, like facial hair, body hair, and voice change. They also affect bone and muscle development and metabolism. So, very important in these levels need to be checked if there is a delay in development of males, right? But in today's society, we also are using these drugs for women who identify as men, right? So we're injecting them with androgens, and this is causing them to develop facial hair. It will affect their muscle tone. It will also cause their voices to change. They'll get a little bit lower. So many things to consider when we're talking about androgens. And now, what is the role of androgens in females? In females, androgens are converted into estrogen in the female ovary, and this is essential for female reproductive function. Androgens regulate bone and muscle mass. So in women, the function of an androgen is different. It regulates the female reproductive function, and it's essential for ovarian function and fertility. So when we're thinking of androgens, it's not just men and testosterone. It's women and estrogen. So they are like counterparts for each other. For men, androgens are testosterone. For women, androgens are estrogen. And so many functions in estrogen: follicular development, regulation of all phases of follicular maturation. So, androgens in itself is very, very important in male and female reproduction, male and female development and growth, and the development of male and female sexual. Oh gosh, what was I going to say? A development. Okay, so it is responsible for in men, as we said, the voice dropping, facial hair, muscle mass. In women, it's more breast development, menstruation, and bones. Okay. So androgens are the a hormone, and it is considered a sex hormone. It's produced by the adrenal glands. And in female, there's lots of different androgens that run around out there. DHEASs, DHEA, testosterone. Yes, women have testosterone in their systems as well. And then the estrogen. Um, and in healthy women, the ovaries and adrenal glands produce 40 to 50% of the body's testosterone. If a person has PCOS, it can cause too much androgen production. And with that, it is going to cause facial hair in women and all those sorts of things too, which is not a pleasant experience. Infertility, heavy periods. You'll learn all of that stuff about PCOS when you get into the women's section. And so androgens, again, more functions, sexual desire, bone density, muscle mass, we talked about, strength, adipose tissue, distribution, mood, energy, psychological well-being. So lots and lots of functions related to androgens. Now, let's look at a couple of things. Okay, let's talk about precautions and contraindications. Okay, let's talk about precautions and contraindications when it comes to androgens. And that is prostate and breast cancer. So, definite no-no in patients who are experiencing those two conditions. And you're going to use lower starting doses for older men and for those that are having difficulty entering puberty. So there is a delay in puberty in males. Sometimes we give them a little boost with the androgens. Now, there are a whole bunch of drugs that can interact with androgens, so you're going to want to look at those on an individual basis. And side effects, drugs like this don't come without um, the risk of developing certain conditions, tumors of the liver, peleosis, hepatitis, can occur during long-term testosterone treatment, and they're very serious and can cause death. Adverse reactions of androgen therapy can be fatigue, weight gain, declining bone density, loss of muscle mass, and muscle weakness. So, when you're taking testosterone, you want to, some of the drugs that we were talking about, ephedrine can cause interactions with it, warfarin, diabetes medications, prednisone. You got to be careful with all of those things. And there's a whole list of different medications when it comes to androgens. And so I don't think it's necessary to list all of the names of the drugs here because there are so many of them. So we talked a little bit um, about androgens, and they are used to treat testosterone deficiency, and that can be used for treating testosterone deficiency in males with primary or secondary hypogonadism. Um, and it can be used to start puberty in boys who are late. Androgens can be used to treat certain types of breast cancer in females. Pharmacologic androgen therapy can be used to improve the mortality and morbidity of non-gonadal diseases. They're administered orally, parenterally, sub-Q, topically, transdermal. And um, androgen therapy can have potential side effects like impotence, reduced sex drive, fatigue, mood changes, osteoporosis, cardiovascular disease, and diabetes. And we use this testosterone we're talking about here to replace the hormone when the body is unable to produce enough on its own. So those are all of the things that you need to teach your patients who are going to be starting on this type of a therapy. And we're seeing it more and more in practice. So I hope that this helps understand the use of androgens. All right, now we're going to focus on estrogens. And estrogen is an androgen. Androgens and estrogens are hormones. Estrogens are produced by the body in greater amounts in females, and they are necessary for normal sexual development of the female, regulation of the menstrual cycle during childbearing, and androgens are produced by the body in greater amounts in males. And that's testosterone. So androgens hold a threefold function on female sexual function: increased libido, increased sensitivity and blood flow to the external genitalia, and increases the intensity of sexual gratification. In the menopausal period, a relative increase in androgen level is observed as a result of dramatic demise of estrogens and increase of sex hormone binding globulin. Now, when we're talking about androgens, it's a hormone, right? But androgens are most commonly associated with men and testosterone. So I want to make that clear so that there isn't any confusion about that. Some women have an increase in androgen, and those can be women with PCOS, and they typically will have a chronically elevated luteinizing hormone and insulin levels, and it increases as the androgen production within the ovaries. Hyperinsulinemia prevents your liver from producing sex hormone binding globulin, which results in increased levels of free testosterone in the blood, and that results in the outward appearance that you see in women experiencing PCOS. I've seen so many in my career. I can really point them out without any laboratory testing. Women who have low estrogen levels can cause irregular periods, hot flashes, painful sex and headaches, mood swings, and most commonly we'll see low estrogen in menopause, but it can also occur during in too much exercise, disordered eating, or complications with the ovaries. So in women, the androgens are produced primarily by the adrenal glands in the ovaries. So women have the ovaries. Now, what are some symptoms of high estrogen? Weight gain, heavier light periods, worse PMS, fatigue, fibroids, fibrocystic breast lumps, low sex drive, low mood, or anxiety. And then we talked about low testosterone with the moodiness and the hot flashes and all of those things too. But it can also weaken brittle bones, can be related to that as well. Estrogen has so many functions in the body, it really does. It is involved in bone health, prevents bone resorption and improves the calcium balance, um, protects blood vessels, affect liver metabolism of carbohydrates, lipids, bile, and proteins, increase levels of angiotensin, which can lead to sodium retention in the kidneys and hypertension, can bind to DNA sequences by interacting with intercellular ER alpha and ER beta receptors in the plasma membrane. It can activate intercellular signaling cascades by interacting with ER alpha, ER beta, and or GPER1. I wouldn't worry about trying to understand those things. Estrogens are needed for puberty, pregnancy, the menstrual cycle, and the levels fluctuate throughout the menstrual cycle and decrease after menopause. However, too much estrogen can increase the risk of stroke and blood clots. Some adverse effects of estrogen: breast tenderness, nausea, vomiting, bloating, stomach cramping, headache, weight gain, skin hyperpigmentation, hair loss, vaginal itching. So, estrogen is a steroid hormone, and it can enter the plasma membrane and interact with intercellular ER alpha and ER beta to exert direct effects by binding to DNA sequences. So estrogen can activate intercellular signaling cascades via interaction with GPER1 and or ER alpha and ER beta. Okay, let's talk about some of the precautions and contraindications related to estrogens. And there are different types of estrogens, just so that you know. There's natural estrogen and synthetic estrogen derivatives. Estrogen hormone receptor sensitive malignancies is a contraindication. Breast cancer, ovarian cancer, and endometrial cancers, all contraindications for the use of estrogens. Coronary artery disease, history of thromboembolism or phlebitis. And one of the things, too, um, if you're taking a hormone during menopause, you want to contact your doctor immediately if you experience any confusion, difficulty speaking, double vision, headache, signs of a stroke. And if you are taking it for long periods of time, it can increase your risk of breast cancer, endometrial, or uterine cancer as well. You want to avoid smoking, it increases the risk, and grapefruits can interact with the medication to cause side effects. So, those are some teaching points. The most commonly used estrogen is estradiol. It's the most common form of estrogen hormone for hormone replacement therapy in the treatment of symptoms of menopause. Some the name is Premarin, estrase. Those are a couple of different names. Another point that's really important, okay? If you have a patient who has a uterus, you're going to treat them with estrogen and progesterone. You will not treat them with estrogen alone, okay? And estrogen and progesterone, those are sex hormones used for the treatment of menopause and or ovarian hormone therapy. And this is what is used for women who still have a uterus. Now, there is some literature out there saying that taking estrogen with progesterone, if you have a uterus, is not necessary. And it may be old school, but I wouldn't prescribe it uh, without it in people who have a uterus. All right, so I think that that's pretty adequate for estrogen. We'll move on. All right, now we're going to talk about progesterones. It's a steroid hormone, plays a big role in female reproductive cycle, pregnancy, and embryogenesis. It acts through the intracellular progesterone receptor, which binds to the hormone and translocates to the nucleus to bind to specific DNA sequences. This alters the transcriptional activity of certain genes. So it binds and activates to nuclear receptor PR, and it is an important part in the signaling of stimuli that maintain the endometrium. Um, Progesterone-only injectables prevent pregnancy by the inhibition of ovulation and the thickening of cervical mucus. So progesterone-only injectables are Depo-Provera, and that is a birth control. You can use this while breastfeeding. It's safe to use in breastfeeding, and it's safe to use in women who have had issues with blood clots. So we talked about that. Progesterone works by thickening your uterine lining and creating a good environment for a fertilized egg to implant. If an egg isn't fertilized during the cycle, the corpus luteum breaks down, which decreases progesterone level. So this is talking about progesterone in pregnancy. One of the primary responsibilities of progesterone throughout pregnancy is to maintain a decreased level of vascular tone in the myometrium. Progesterone also influences the production of inflammatory mediators like human T cells within the uterine category. So progesterone is imperative in menstruation, pregnancy, and sperm production. So men produce progesterone as well. Some of the symptoms of too much: irregular periods, trouble getting pregnant, mood changes, anxiety, depression, trouble sleeping, and hot flashes. The most common problems with progesterone: low levels can cause irregular periods, spotting, and headaches, and makes it difficult to get pregnant. Who should take progesterone? Um, Women who are at risk for premature birth, if women have a history of early pregnancy loss, infertility, or irregular periods, it can increase the chances of a successful pregnancy. Now, some of the signs of low progesterone: irregular periods, headache, difficulty conceiving. We spoke about all of those things before. Okay, when we're talking about progesterone birth control, this is the mini pill, a hormone contraception that contains synthetic progestogens, and no estrogen. It prevents pregnancy by stopping the ovaries from releasing an egg each month, and it makes it harder for a fertilized egg to attach to the uterine wall. And so this is what you want to use for women over 35 who smoke, have high blood pressure, history of blood clots, or migraines. Migraine is a contraindication to using estrogen birth control. So that's an important fact to remember. Okay, I had talked earlier about the Depo shot, and I wanted to make some clarification. The Depo Provera shot is a contraceptive injection that contains the hormone progestin. Okay, progestin. So that's different than progesterone. So I just wanted to clarify that, and I think that's pretty good. All right, let's talk about topical anti-infectives. You're going to be using a ton of this stuff and a lot of skin stuff. Skin is, I think, one of the most challenging conditions to diagnose and treat, and that's only because there are so many different skin conditions that cross the line over each other. So, atopic dermatitis has different characteristics that are maybe similar to psoriasis. Um, Cellulitis may have some characteristics that are similar to atopic dermatitis. I mean, there's a lot of overlap. So, differential diagnosis is very important. Very important. I'd probably say I use differential diagnosis more often with skin than I do with anything else. so that I can know if I treat with this specific treatment modality and it's not effective, then I'm going to go to number 2 on my list and treat for that. Always reevaluating to ensure that I am treating appropriately. So anti-infectives are applied to the skin, the nail, mucous membranes, vaginally to treat infections. Typically, we have damaged skin, burns, wounds, cuts, or scrapes, as well as surgical incisions. All of those things are considered. Um, I can't. Why isn't this working? So, topical anti-infective agents act by killing or inhibiting the spread of the infectious agent. Remember, antibacterial uh, ointments or creams work just as antibiotics do in the body. So, we are prescribing something that is going to target the bacteria that is causing the issue. Now, on skin, staph is a big deal. Okay, we see a lot of staph infections on skin because staph is normally on the body and but not at levels. It's meant to be on the body, not in the body. Okay, so and it's typically at levels that don't make us sick. Occasionally, yes, it will. So we need to consider that. Okay, now just to elicit that a little more uh, succinctly. Okay, aminoglycosides, macrolides, chloramphenicol interfere with steps involved in protein synthesis, rendering cell division non-functional. So that is how they work on bacterial infections. Fluoroquinolones interfere with the DNA synthesis, leading to the inability to divide and ultimately cell death. So those are just 2 examples of how this works. So hold on a second, my pad's and some more, different mechanisms of actions with antibiotics. And you think about I always remember, and I'll say this over and over again, that you want to use the antibiotic that is going to target the bacteria. So consider it. Azithromax is a macrolide. What does it treat well? What does it not treat? It treats pneumonia. It doesn't treat sinusitis. Why? Because there's different bacteria in the sinuses causing sinusitis than it is in the lungs causing pneumonia. So you want to target the mechanism, the antibiotic that you want to use. And topical anti-infectives come in different forms. They can come in, usually it's creams, ointments, gels, or solutions. Topical ointments, it's something that you need to consider, can be absorbed through the skin and actually go into the bloodstream. So that's a consideration uh, for anything that you're treating. If a patient is allergic to a, a specific medicine, you want to make sure that that antibiotic or that medication is not in the medication that you are prescribing. Oh, I'm having challenges with my iPad today. Okay. All right. So topical medications, anti-infective agents have a low drug-to-drug interaction because there's minimal exposures to other, even though it does cross in, very very minimal. So um, topical drug interactions can occur between two topical drugs or between a topical and a systemic drug. Um, it doesn't happen very often, but it can happen. Okay, let's talk about topical um, anti-infectives a little bit and talk about, if a patient comes in, or they have a minor wound, it's healing well, just a daily wash with soap and water is adequate. They don't need anything. We're using these anti-infectives for um, wounds that appear to be infected. There's redness, swelling. um, I consider the intensity of the infection deals with the treatment. They may need oral antibiotics if it's a cellulitis. Topicals just aren't going to cut it. They're not strong enough. If they have impetigo around their, in around children, typically will get it around their mouth and in their nose. It's characterized by golden crusts. I'll use mupirocin, which is an antibiotic, because it will treat MRSA also. A lot of antibiotics will not, the topicals. So I want to ensure that I am using a drug that is going to capture whatever I am trying to eradicate from the system. So I may use um, if someone is buying an antibiotic over the counter, that's fine. But I tell them not to buy Neosporin. Neosporin, many people have reactions to Neosporin. Bacitracin is what I recommend them get if they want to keep it in the house for, purposes in the event that there is an infection or a wound, um, that they want to put an agent on. Bacitracin is what I recommend. But nothing can beat just plain soap and water for a wound. Um, Not a lot of drug interactions. I wouldn't worry too much about that. Um, and Okay, so let's go a little step above. Okay, let's talk about the broad range of topical anti-infectives. Okay, it's not just antibiotics. When we think of anti-infectives, we automatically think of antibiotics, and that is a big piece. That's why we spent a bit of time discussing antibiotic use in um, topicals. Okay, but there are other anti-infective agents that we use, and it can be fungicides, germicides, bactericides, disinfectants, antibiotics, antibacterial, antifungal, antiviral, anti-infectives, and they can come in creams, ointments, shampoos, and powders. So there's a lot of stuff, right? A lot of things are topical anti-infectives. So let's see. I talked about the patient that comes in with impetigo. That is a staph infection. Typically, we treat with mupirocin, which is an anti-infective that I know covers MRSA. Okay, so um, if it is not a bad case, if it is minimal involvement in the nares and upper lip, I will use a topical. If it is more extensive, covers more of the face, I will use the cream, and I will also prescribe an oral antibiotic because the cream is just not enough. It's just not going to cut it, okay? Now let's talk a little bit about fungicides. I use those a lot. Um, you are going to use this commonly in uh, skin infections that are related to fungus. Oh, I don't want to lose that. Okay. Um, and those are the classification of illnesses called tinea. You may recognize the word ringworm, and these are a common fungal infection. And the fungal infection is treated with an antifungal. Now, you might think, okay, I'll buy an over the counter antifungal that they treat for like athlete's foot or something like that. And usually those are just not effective. They're not as strong as they need to be. But I prescribe ketoconazole. Anything ending in a zol, okay, that's an antifungal. I treat with ketoconazole because they only have to use it once a day. And one of the important aspects of ketoconazole is that, and with tinea, is that it must be used a week prior or a week following the resolution of the skin infection to ensure that you have uh, alleviated all of the fungal spores from the area. Now, tinea capitis, which is ringworm on the scalp, is much more difficult to treat. There are shampoos that you can use. Most of the time, they need oral antifungal treatment. And in the event you're going to do that, you need to get liver enzymes um, because it can cause issues with the liver. All right. What else can I talk about? Oh, let's talk about yeast. Okay, yeast infection. You're going to use a topical, right? That yeast infection is fungal. People commonly get it if you have large breasts underneath the breast in the summertime, if they have the large pannus on their abdomen underneath the pannus. Vaginal yeast infections treat with monostat, or you can use diflucan. And I treat with either ketoconazole or something like that. Let's talk about virals. Okay, cold sores. Could you get a cold sore? I'm going to treat it with oral Valtrex. Um, Valtrex comes in 1,000 milligram capsules. And if you have an outbreak of a cold sore, I'm going to treat it with 2 capsules, which is 2,000 milligrams now, and 2 capsules, 2,000 milligrams in 12 hours. And that's it. But if they need quick resolution, I will also prescribe an acyclovir ointment, which is an antiviral. The treatment is different in shingles. Shingles is, it's all the same family. Shingles, and they're all viruses that have to do with the fact the virus gets attached to a nerve. A shingles, I'll treat with oral Valtrex, and that is 1,000 milligrams 4 times a day for 7 days. So it's a much higher dose of medication for that. And I think that's about it. But you've also got on men, you have the well, commonly called jock itch. That's a fungal infection. On the feet, that's a fungal infection also. So we need to know what we're treating and treat it appropriately, um, and use appropriate drug selection when we are considering anything, and that includes skin conditions. Okay, so we're going to talk a little more in depth of the topical systemic antifungals, topicals and systemic antifungals. So we talked about this, um, and they treat fungal infections in the skin, mucous membranes. I forgot to talk about that one. Yeast in the mouth, used with nystatin, um, and they swish and swallow the nystatin. External genitalia, tinea corporis, intrigo, and intrigo is different than impetigo. Intrigo is a skin condition. It's really weird. I want you to see a picture of it. I wish I had a picture of it, but look it up on Google. It is the area is lighter in this area. So you have an area of the skin where the pigment has changed and it's now lighter. Um, let's see. So some of the examples of the topicals are terbinafine, that's Lamisil. You buy that over the counter, black. Um, Tolnaf- Tolnafate, that's over the counter also. But like I told you, I use ketoconazole. Nystatin is what you're going to use in the mouth for oral, and the topical or the systemic is fluconazole or diflucan. There's also ketoconazole, which is in an oral form, terbinafine, and griseofulvine. I probably said that one wrong. Sorry about that. Now let's talk a little bit about mechanism of action in antifungals. Once you administer them, the topicals work by disrupting and damaging the fungal cell membrane. So that's its function. It damages the fungal cell membrane so it cannot continue to survive. So ultimately results in a fungostatic action, so it stops fungal growth, or a fungicidal, which means it kills the fungi. Oral anti or systemic antifungal medication involves a disruption of spindle and cytoplasmic microtubule function, depletion of or binding to, and oh wait, yes. So um, I made a mistake here. So let's sidetrack a little bit. Griselfulvin, it causes a disruption of the spindle and cytoplasmic microtubule function. Okay. Terbinafine, ketoconazole, and amphotericin, and cause a depletion of or binding to orgestrol. I don't understand what that means. Ergosterol. Ergosterol. I don't know. I don't know what that is. So the systemic antifungals either kill the fungus or inhibit the fungal growth. There we go. Got it. And fungal infections are super common. You're going to see them a lot. I always know when wrestling season starts because I have all of the kids coming in with ringworm. All right, let's talk about drug interactions. They have a low risk of drug to drug interaction. The topicals do. Then oral antifungals, but they still can interact with other medications. The interactions that we become concerned about is prolonged QT intervals and neuromuscular toxicity, torsade de pointes, and uh, rab- rhabdomyolysis and death. Oh, so we don't want to co-administrate with phentoin, phenobarbital, carbamazepine, rifampicin, isoniazid, ritonavir, efanviz, efanvirens. Um, so we want to avoid that. If you're on a statin and you're taking an oral antifungal, it increases the simvastatin acid by 15 to 20 times. So this is really something that needs to be considered. So it's is going to significantly increase the blood levels of that statin, and it can cause liver damage. Okay, so when you're considering rational drug use, now you also are going to consider toenail fungus too. Toenail fungus typically they've come out with a new topical. It's very new, so I don't have any information on it, or I'm not able to comment on it because I've never used it. But other than this new topical treatment, other topical treatments are ineffective against toenail fungus. You need to use an oral antifungal, and the treatment goes on for months. So let me see. Um, all right, let's see. So the a topical antifungal treatment for toenail fungus needs to be used at least 6 to 12 months. That's for a topical, if it's going to work. Okay? And let me put in it can take 12 weeks up to 4 months or longer for the orals. Okay, so that's a really long time. And remember, we need to check liver function when you're taking those antifungal drugs.